5 surprising reasons your kid doesn't want to swallow that food. And as I was saying earlier, I'm here with my friend, Barbara Covid Ellis, who is not only an experienced clinician with both pediatrics and adults when it comes to swallowing disorders, but she's also the brand new author of Tyler Takes a Taste, which is an adorable book for both children and adults. I really enjoyed reading it because it's informative for parents as well. But I asked Barbara to be here tonight because I really respect her opinion when it comes to swallowing difficulties. She's often on the American Speech Language Hearing Association's listserv and answering a lot of questions, especially for our young clinicians, about maybe what's going awry with one of the phases of swallowing. So, Barbara, I thought we would start there, if you don't mind. Would you just explain to, especially all the parents listening, what are the 3 phases of swallowing? And I think maybe I might even use my throat scope to kind of help light it up as we go. So, and you can use yours too if it's easy. But explain to everybody the 3 phases of swallowing.
Well, I'm gonna add a little to that because I actually like the pre-phase, which is because people obviously think about eating and drinking once it starts in the mouth itself, right? But we actually prep before the food gets to our mouths. Mm-hmm. And so that's one of the things when we're feeding kids we have to think about. So little kids that are sitting back in their high chairs like this and we're, feeding, they don't get what we call the oral prep stage. And the oral prep stage is where our mouth gets ready to accept food. If you think about it, when you pick up like a hamburger, you don't just bring it to yourself like this. You lean in and you take this bite. And when you do that, all of this musculature gets ready to take in food. When you're back here, your tongue's not ready for it yet.
That's so true.
That's the pre. Then we have the oral stage, which is where your mouth does all the chewing. Exactly. Your mouth takes care of the food itself, takes a solid, mushes it up into that nice wad that we can swallow. Then we have what's called the pharyngeal phase, or the throat, right? And that's where it's going down here, and we want it to be going towards our stomach instead of towards our airway. And that's where things can get a little dicey for some people.
Sure.
And then we've got this part right here, the esophagus, and that's the tube that goes from our throat all the way down to our belly. And that's really, really an important stage too that people don't really think about and how that affects what's happening up here.
That's so, I love the fact that we're talking about when it goes down the wrong pipe. That's a phrase we all grew up with. Oh, it's going down the wrong pipe, right? But it truly is that it's not, instead of going down the esophagus, it's trying to go down the trachea. And that doesn't mean that the whole bolus, the whole piece of food goes down, because although that may happen and cause significant choking and child turning blue, we can actually have pieces go down the wrong pipe. And
just itsy pieces, or a little bit of liquid, in particular liquid, or liquid and a little bit of solid. And all of that can give you that really awful cough. But there's also a thing called silent aspiration, which means it sneaks into the airway and you don't cough. That's pretty complex. But the big thing about that is, especially for littles, babies in particular, if they have that experience repeatedly where it's going into the airway, later on as they get bigger, what can happen is they start not wanting to eat because it's uncomfortable and they know it's going the wrong place. They know something is wrong.
And right? They don't feel safe.
And that's how aversions can develop, where we get these kids who are absolutely aversive to eating. And we think, well, wait a minute. Well, nothing's wrong. Why? They're not coughing, but it's going in the wrong way. And there are other signs and ways of figuring that out. Like you were saying, there are special tests that we can do. And one's called a modified barium swallow, and that's my favorite. Because what it is it's while somebody is eating and drinking, we actually watch the process on an x-ray. And then we can see if things are peeking into an area that they shouldn't be going into. And then we can figure out what kinds of therapy we would like to do, or maybe we have to modify things a little. Sometimes it has to do with things called thickeners. But I'm one of those people who, if I can avoid a thickener, I don't do a thickener. I'd much, much rather fix it.
I agree. I agree. So we've been talking a little bit about the different phases of the swallow, and the modified barium swallow catches a lot what's going on when the mouth is closed and we can't actually see in there. But when we are doing our oral exam, we can look in and look way in the back. What do you think about when you see two or even just one gigantic boulders back there? Can we talk a little bit about tonsils?
Okay. Well, tonsils are oftentimes the reason that kids can't transition from liquids and purees, things that are semi-liquids, to solids. And if you think about it, if you've ever looked into a kid's mouth, or into your own mouth for that matter, and everything is swollen back there, there's so little space. And what can happen is a couple of different things. Food can get caught on it and it's uncomfortable and painful. Other times it'll cause the kid to gag because the food fills that space, and then there's pressure on the back of the tongue and it's cool. And who wants to eat when you feel like that? So the kid says, nope, not doing solids, sticking with those liquids where things are comfortable. And so we have to get an ENT involved at that point. And that's one of the reasons that an SLP always looks at somebody's mouth.
Always, always. And we have to do that on a regular basis. One of the reasons why I really like this new system that Holland Healthcare has devised, that Jennifer Holland invented, they've taken the throat scope, and now you can actually attach it to a phone with an app that can measure the distance between the tonsils and send that information to your doctor on an almost daily basis. If we're monitoring, is this just a one-time virus? Is this happening all the time? Does it happen more in the morning after the child's been sleeping and maybe has an open mouth? It really gives us a chance to be a good detective and figure out what is contributing to that narrow airway, which is also going to make eating hard. And what could we do to possibly shrink those tonsils, or would they have to be removed? Because naturally that's a surgery. We don't want to just jump right into that, but we've got to get all of that information to help the parents make a good decision. I wrote an article for the American Speech Language Hearing Association. I'll actually put it in the comments here when we're done, about structures in the child's mouth and that can impact picky eating. And one of them was tonsils. I see it a lot. But oftentimes someone who's not as experienced with feeding will say, no, he seems to eat fine. And if I say, well, what does he eat? He eats macaroni and cheese because it's slippery. You can squeeze the macaroni and cheese through the narrowest little slot there. You can have gigantic tonsils and it'll still squeeze through. They're eating from pouches. They're drinking a lot of milk. I even had a child who had huge tonsils, barely any space between them, who could eat a bagel. But as my friend Erin Geddes, who will also be on one of our episodes here soon, talking about thumb sucking, Erin pointed out to me, Melanie, that's because they're loaded with gluten. And gluten, when it gets wet, is slippery. And so it might be a big chunk of bagel, but it just pushes those little pillows back a little bit and slides right through. It's just naturally a lubricant, which I thought was brilliant. And that was the one food that he would really, really chew. But now I understood why he could swallow it and couldn't swallow anything else that was similar. So as I said, it does take a lot of detective work. So we were chatting too about being smart about that oral phase and really being a good detective and making sure that the kids aren't just squishing and swallowing. Because if they're squishing and swallowing with their tongue, they're not doing what?
They're not chewing. They're not chewing. And the thing is, it's really tricky because the jaw's going up and down. I
Mhm.
have parents tell me all the time, I'll say, so you're talking, he can't really do solids. Does he chew? And that's, oh, of course he chews. His jaw's going up and down and up and down. I say, oh, okay. So, and then like you, I talk about they ask about what kinds of foods. And all of the foods that they're able to eat are ones that they can take their tongue and squish it against the top of their mouth and make it soft enough to make it down. Um, Going back to your tonsils for 1 second.
Yeah.
The other thing that kids will do sometimes, take a sip of milk or juice to slide it down and slide it past. So even with a more solid food, they kind of treat it like taking a pill.
Yeah.
And it's brilliant, but once again, it's not particularly functional and it's not particularly safe. But okay, going back to the mouth and chewing. So when a kid's going up, the mouth is going up and down, what it's supposed to do, let me get out my little throat scope here. Your tongue is supposed to take your food and put it over on your molars. Mm-hmm. And then your molars do the actual grinding of the food. They make it up into that, they break it down into that paste that then we can put into a wad, what we all call a bolus, and pull back and swallow. But if they're not breaking it down with their teeth and they're only using their tongue, they're going to be very limited on what they can do. I'll bet you have people tell you, though, yeah, but my kid can do really hard, crunchy foods like crackers and veggie straws. Oh, they love graham crackers. And you're going, yeah, but those are foods that we call meltables. And basically, those can break down with spit. And if they break down with spit, they can cheat. They don't have to use their teeth.
Exactly. Even certain fast food chicken nuggets, those are just cheap chicken. You break them apart and it's nothing but little tiny pieces of chicken. You don't even need to eat those. You really don't. So I think we keep getting back to the fact that you've got to be a real detective to figure out what's going on with these little kids. And I think especially you mentioned silent aspiration, but let's talk about, rather than the food going down, what happens when the food goes up. A lot of times kids don't want to swallow because the food is coming back up, either in the form of silent reflux or possibly back up higher into their mouth. It doesn't happen all the time, but it happens enough that eating just isn't comfortable and it isn't pleasurable. So why try a new food when you're going to always get it reinforced by an unpleasant experience? You're not going to eat food. Do you see that a lot, especially with the testing that you do at the hospital?
Oh, we see it so much. It's one of the reasons that when we do an MBS, I always request, if I don't do pediatric, I don't do adult MBSs, so I have to send out for my pediatrics. But one of the things I always request is that they please do what's called an esophageal sweep, which means that after the kid swallows, we see what's happening down here. Mm-hmm. And the reason is oftentimes foods will come down. They'll come down to about here and they'll get stuck.
Right here.
Yep, right there. And then they start burbling back up. And when it burbles back up, we've all been there. When you're eating something, you're eating quickly, or maybe you're eating something really dry and you go, and you drink some water and you just feel this pressure in your chest and you go, oh, I think I'm choking. But you're talking. So if you're talking, you're not choking, because that means your airway is blocked. But instead, it means something's in your esophagus and it's stuck. And sometimes it comes back up. Sometimes it goes back down, but slowly, 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 and kind of like works its way back up again. And when it does that, it can really burn too. And we can have a thing called reflux. And we've all heard about GERD for adults. Kids can have it too. And they don't really know how to tell you that it hurts. They just know that when they eat, they're really uncomfortable.
I agree. And oftentimes we'll get 3, 4-year-olds who are extreme picky eaters. And again, getting back to our detective work, when we look back on their medical records, they actually had a history of gastroesophageal reflux diseases, maybe in infancy. It appeared to resolve, but that doesn't mean it wouldn't necessarily come back or that it wasn't really resolved in the first place. But the main thing is they learned early on that eating's uncomfortable. And even if medication took care of it, they still are like, I don't want to eat that, because they had that difficulty in the younger years being comfortable with swallowing. As you were describing there, Barb, I always talk to, when I'm speaking to students, that you have to remember that from the moment you put the food in your mouth and close your lips to, pardon me, but the moment you poop it out, right? It's all one long tube, as you often say.
Absolutely.
That is a series of pressures and valves. So if you have a lot of pressure in your belly for whatever reason, maybe it's bad positioning, maybe it's constipation, there's so many different reasons, it will cause the food to rise, maybe not all the way to the point of the tonsils, etc., but enough that you get this pressure right here.
Oh, yes.
And when you have that it feels like you have a burp that won't come up, only sometimes it can be really painful or even burn. But even just the pressure, the kids will arch, they'll wiggle, they won't want to stay in the high chair, or they're 3 or 4 years old and they just don't want to stay at the table. Because when you stand up and you walk around, it helps to relieve that pressure. So again, we're paying attention to the child not only while they're eating, but also before and after.
So, well, and gravity, you said, when they're walking around, that gravity helps move it down. And to add to that, there's a thing that happens with stomachs sometimes where the stomach doesn't empty the way we expect it to. And normally what happens is, the food goes in, it gets munched up by all of the acid and the stomach action of moving it. And it moves through in a timely manner. Some people that doesn't happen with, and it's called slow gastric emptying. And when that happens, that feeling you get when you're full after a meal and you're just too full and people say, oh, how about a piece of pie? How about a piece of whatever? Imagine, yeah, exactly. Imagine that keeps with you for hours on end. And that's what happens with this delayed gastric emptying. The stomach is not emptying. And so you were talking about the pressures. You put something down, it wants to come back up.
Exactly. And you just, you might take a little bit more of your highly preferred food, but not much. And it's another reason why we often see kids kind of graze all day, so that they already have kind of a full stomach because what they ate earlier isn't emptying through. So they just sort of nibble all day. Yep. There's a lot of medical reasons for this, but the final one that we want to be sure we chat about is something that speech language pathologists look for all the time, especially with my slightly older children who can verbalize to me that they feel like they have something in their throat, just one of the symptoms, and that's eosinophilic esophagitis, which is it just in short, an eosinophil is a white blood cell, and we all have them. We just shouldn't have a lot of them, and they're there to fight off infections, etc. But when a child has an invasion of eosinophils or white blood cells in various parts of the GI tract, in this case, we're talking about the esophagus, they could even have as few as 10 to 15 roughly to warrant a diagnosis of eosinophilic esophagitis, which is an incurable disease. We can manage it with medication and some other strategies, but it really makes it uncomfortable to swallow. I was wondering too, if you would just briefly comment about what happens to the esophagus if eosinophilic esophagitis has gone undiagnosed for a little while. What do you see in some of the tests that you're doing with these kids?
Well, Normally, the esophagus is this nice, smooth tube. The way I like to describe it is kind of like sausage casing. It's not that different or that different from your intestines. And so it's very pliable. And that's why a bigger bite can go through and a small bite, and it opens and relaxes. When we have had a long history of EOE or a long history of really severe reflux, it stops being so lovely and flexible. Normally, what it does is it does a thing called peristalsis, where it goes squeeze, 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 and moves things all the way down from here to here without any real effort, right? But what happens with something like EOE is there can be scarring inside. There can be strictures, which means that there's a narrowing and a place where it doesn't open up and stretch like it should, and things will get caught on there. We get a lot of people who end up in the hospital, adults in particular, who you get a blockage and somebody has to go down and pull it back out. Mm-hmm. Some people can rinse it through with liquids and things, but if you've got that feeling regularly, why the heck would you want to eat? You know, there's all sorts of different things that happen to that lovely, lovely flexible tube to make it not do its job anymore. So we've got to get GI involved so that they can take a look. They go in, they look and see what's happening, see if they're seeing the kinds of things that indicate this. They usually take a little piece of tissue so that they can test it. And then from that point, we can move on, because this is not going to be able to be treated until this is comfortable.
That's so true. I think one of the things to really consider is that when kids are having difficulty swallowing, we could probably spend 2 hours talking about all the different possible reasons.
Oh, yes.
But I wanted to at least tonight highlight these 5 reasons, including EOE, because EOE between children and adults, although it's a relatively rare disease, the prevalence is still 1 in 2,000. So yeah. It's something that we still take very seriously. And I work really hard when I'm teaching to make sure that all, especially our young therapists, are aware of that disease as well as others.